So today's lesson is back pain evaluation part 1. As I told, we'll be starting it in 3 parts. So today is part 1. And we'll be starting with one, poll. Have you ever experienced back pain? If it is never, put on the red, never. If sometimes, put on sometimes. If it is often, often. And right now, if you are having back pain, you put it on the right now, you are having back pain. This is a small survey to understand how common is back pain. Okay, so you see how many has responded? So responded is 20 plus 2, 12, 32 plus 6, 38 plus 4. So 42 people responded and only 4 never had any back pain. So you understand, the lifetime prevalence is what? Lifetime prevalence is more than 80% is lifetime prevalence. That means everybody in some part of their life, they suffer from back pain. So it is so common. And in any pain clinic, back pain is one of the very, very important reason why a patient come to a pain clinic. So all of you have to be master in evaluating back pain. You cannot do any mistake there. So evaluation as well as how to do the management and the interventional part as well. Right? And you see the point prevalence, it's something here it is 6. That means 6% out of this 42, right now they are suffering from back pain. So it's so common. So we'll be dividing this into this part. First is, what are the causes? And unless you know what are the causes of the back pain, you can't evaluate. So you must be knowing what are the different causes, what will be your clinical features, what is the symptoms, what are the signs, how you are going to, make a diagnosis. So this part is the first part. Today, I'll be causing that. From next class, that means next Wednesday, we'll be discussing about the red flags, how to take the history, or the very important areas, the history, the clinical examinations. So this will be covering on the part 2. And part 3, we'll be talking about this, particularly the MRI. X-ray CT also will be talking, but we'll be talking about the MRI and ultrasound. That will be on the part 3. So whole this journey, we have divided into 3 parts. First part is today, causes. Next part will be red flag, history, clinical evaluation. And the third part will be ultrasound, X-ray, CT, MRI on the third part, part 3. And obviously, differential diagnosis will be automatically coming. So now, very important concept in the pain medicine is pain generator. What is it? That means suppose a structure don't have a nociceptive innervation, neither physiological nor pathological. You understood what is pathological innervation? On the first class, we have discussed about the pathological innervation, sensitization. And in the sensitization, what we told that some structures which might not have any nerve, but in pathological conditions, newer nerve endings might be growing in that structure. So earlier, that structure was not a painful structure. Even if you are cutting, there is no pain. But after this pathological innervation into that area, that structure becomes a painful structure, right? So I told on the first day that the nerves are not a static structures, it is dynamic structures. And we call it as a neural plasticity. Nerve pattern connections, nerve cell number is same, but the axons and dendrites can grow into the area where there was no innervation earlier. And the classical example is disc. I'll be talking about this disc today, that inside the disc, whole of the nucleus pulposus and 2/3 of the annulus don't have any nerve physiologically. But when the disc gets degenerated, then the nerve endings grow inside to innervate the inner 2/3 and the whole of the nucleus pulposus. So earlier, the disc which was not painful now become a painful structure. So what is a pain generator? Pain generator must be having either a physiological nociceptive innervation or it must be having the pathological innervation. If a structure don't have a physiological or pathological nerves, that structure cannot be a source of pain. This is very simple thing. And the next part of it, how as a physician, we are going to identify which structure is responsible for the pain. Very simple. Give local anesthetic into that nerve or into that structure, into the tissue. And if the pain is relieved more than 50%, that structure is responsible for pain. So, so this study was done in, the early 90s. So what was done here, the investigators, they collected the patient suffering from back pain. And with all the imaging, with all the clinical tests, they couldn't come to a conclusion that which structure is responsible for the pain, what is the source of the pain. And then they did this test. So what they did? They did local anesthetic injection into the facet joint, into the sacroiliac joint, in the nerve root, small amount, into the disc, and then they tried to find out where are the pain generators. So the similar kind of studies, lots of studies are there, and which tells earlier, we used to call that more than 80% situations, the cause of the back pain precisely couldn't be understood. We call it mechanical back pain. Mechanical back pain is a very big term. Whenever we are unable to understand anything, we call, okay, it's mechanical back pain. But mechanical back pain is not the end. With that, we can't understand anything, which structure is responsible. So, in the hand of the pain physician, we have some answer. What is that? You go on injecting local anesthetic into the facet, into the SI, into the disc, and try to understand that in the back, these are the structures in the back. There is no other structures in the back. So, if these structures are painful, the local anesthetic injection will be giving pain relief more than 50%. So that is how we can identify the pain generator. So this identification of the pain generator is one of the very, very important revolution in understanding the back pain. And then we can understand what are the structures, how many percentage. I'll be coming to that one by one. So right now we try to understand what is pain generator. A pain generator is a structure who have a either physiological nociceptive supply since birth or might have nose nerve earlier, but now the pathological nerve has grown in that. So now that structure can be a source of pain. We call it as a pain generator. So we have to understand that what are the different pain generators. So we'll be discussing today's topic is what are the pain generators in the back. And clinically, how can we suspect who is the pain generators? And then by investigations, we can confirm it. So with these local anesthetics, scientists, physicians have identified that these are the major sources of the back pain, means major pain generators: disc, facet joint, sacroiliac joint, muscles, skeletal muscles, ligaments, vertebral body, bursa, and also hip joint in the differential diagnosis. Remember that hip joint examination, unless you are doing that, your evaluation is not complete. Okay? So now a quiz, quick quiz, response it. Which one is the commonest pain generator in the lumbosacral area? Facet joint, SI joint, disc, or paraspinal muscle? So major pain generators in the back is disc. Okay. Though recent studies are telling paraspinal muscles are also very important, but still now, whatever the available data is there, we can call a disc as the most common pain generators in the back. Others are also important, but most important structure in the disc is the back. Okay. So first part in our understanding is the question we need to answer in the while we are evaluating is where from the pain is coming. Where is my pain generated? So whenever you are evaluating, this question will be always in my mind. We will be trying to solve this question, that where is the pain generator? But that is not enough. The second question is also important. Like, say, for example, simple example, that facet joint is the source of the pain. So you can tell that the yes, facet joint anatomically is responsible for the pain. But why? Why facet joint is pain? Or why the patient is having the pain coming from the facet joint? Normal facet joint should not produce any pain, isn't it? So if the facet joint is the source of the pain, then there must be some pathology. So we have to answer the second question as well. Why? And this why list is not a very big list. So we know that in the why list, the most common thing is your degenerative conditions. That is the commonest. And that is the reason why the elderly people suffers from the pain much more than the younger population. So one of them is degeneration. Next, trauma. Next, inflammation. Any of the inflammatory arthropathies, infection, malignancy, metabolic disorders. So these are the answers for the why. But out of this whole list, the few things are common. One is your degeneration, trauma, inflammation. These three are the top of the list. The malignancy, the metabolic reasons, infection, these are not that common. So in our list, we will be trying to answer whether understand that why. So where and why. If we are answering these two questions, our job is done. Our evaluation complete. In the back pain, if we can tell that, okay, the facet joint is the source of the pain, and this is because of the degeneration of the facet joint, so our diagnosis is complete. Then you can plan for the management. And unless you are having the answer for these two questions, then your management plan will not be complete. Say, for example, you understood that it is from the facet joint, right? But you couldn't understand that this was because of the inflammation, autoimmune spondyloarthritis, ankylosing spondylitis. So you have done a facet joint injection nicely. What will happen? It will be, oh, doctor, you're a very good doctor. My pain is reduced completely. And then after a month, he's coming back telling, sir, my this side is painful. And you saw that, okay, sacroiliac joint is causing pain. And you have put another injection on the left side sacroiliac joint. And then after 1 month, again, patient is coming back. Doctor, my this side is again painful. So how long intervention will you do? Or you will go on intervention, doing intervention every month. So we have missed the diagnosis that this patient was suffering from ankylosing spondylitis or spondyloarthritis. And that is the reason that many of these facet joints, sacroiliac joint are getting inflamed. So unless we are understanding why, so if we have understood it, this is because of the inflammatory arthropathies. So we could have given the disease-modifying drug or biologics so that there was no need of doing any interventions. We could control the inflammation and we could control the pain as well. So understand, where is first part, second part is why, and if we understand these two problem, then your evolution is complete. So first we'll be talking about the disc. So again, if the answer is where answer is disc, then why answer is these three different conditions. All these things are because of the disc degenerations, but they can present as three different clinical entities: internal disc disruption, disc prolapse, and canal stenosis. And we'll be discussing a little bit about these three conditions and the disc degenerations itself. So if you're looking about the disc, so disc has three important structures. One is annulus. This outer layer, thick fibrocartilaginous structure is annulus. And then we are having the annulus. And then we are having the nucleus pulposus. That is a soft gel-like thing. And third structure is your end plate, cartilaginous end plate, one above and one below. So out of these structures, the nucleus pulposus function is what? It gives the flexibility, pliability, because it is fluid. So we can bend the spine in the different direction. If it was solid, we couldn't bend our spine. But annulus is the most important structure. Annulus, there are different layers, and their fibers are opposite in the, if this direction is this, the next one direction is like this, so that it is reinforcing and giving the strength to the boundary wall. So this forms the boundary wall. And this also provides the nutrition. If you're looking about the blood supply and the nerve supply of the disc, only the outer 1/3 is innervated and has the vascular supply. The rest 2/3 of the whole of this nucleus pulposus and annulus and the nucleus pulposus don't have any blood vessels or any nerves, right? So there are live cells there inside, chondrocyte cells. So how they are getting nutrient and oxygen? So it goes from diffusion from the periphery to the center. And how this diffusion takes place? It is facilitated by fluctuation of intradiscal pressure. So if we are keeping interdiscal pressure at a constant level, then the disc suffers from more degenerative conditions. Why? Because if suppose we are giving bed rest, so what will happen? Interdiscal pressure will be constantly low. So what is important? That we should change our posture so that the interdiscal pressure actually fluctuates. So interdiscal pressure is high when you are sitting and leaning forward. Interdiscal pressure is little less when you are sitting erect. Interdiscal pressure is still little less if you are standing. Interdiscal pressure is very high if you are bending forward and lifting something. So all this movement is good for disc. Don't think that ergonomically designed chair and you sitting erect is the best posture. No. Best posture is the change of posture. Why? Because with the change of posture, your interdiscal pressure will be fluctuating. Sometimes higher, sometimes lower. And that is the driving force of the oxygen and the nutrients. So disc will suffer from the degeneration if the interdiscal pressure is constantly low or constantly high. So second important function of the disc is what? That supplying the nutrients and the oxygen to the whole of the disc. Because whole of the disc has the chondrocyte cells inside who needs oxygen for its, because it's a live cell. And third important function is, it is of the annulus is, it is giving the disc height. If the disc height is not maintained, nucleus pulposus is fluid, gel, it cannot give the disc height. So this is giving disc height. So what will happen? Two vertebral body will come in closer. If the two vertebral body comes closer, what will happen? Neural foramina will be narrowed. Two lamina will be coming closer. So ligamentum flavum between the two lamina will be folded and coming anteriorly. And that will be causing the narrowing of the spinal canal. So I'll be coming to this point just now. That condition is known as spinal canal stenosis. So first, we try to understand the physiology. I'm talking about the physiology. Then I'll be coming to the different pathological conditions. So you understand that the two important structure, one is your annulus. I've talked about the annulus functions, three important functions. One is holding the nucleus pulposus. It is not allowing it to leak. And this is how its strength is increasing. It is fibrocartilaginous structures. Annulus is a fibrocartilaginous structures. Next important thing is that it supplies the oxygen and nutrients to the whole of the disc. And third important function is it is standing erect like a boundary wall, not allowing the vertebral bodies to come closer, so that the disc height is maintained and the neural foramina and the spinal canal diameter is remaining better, healthier, right? Now, what about the nucleus pulposus? Nucleus pulposus have 80% water. How the water is retained? Why the water is not coming out from inside out? Answer is, it is having the large aggregate and glycoprotein molecules. You just think about our blood. In our blood, what happens? We are having the plasma proteins, and that is giving oncotic pressure. Whereas our blood pressure, the hydrostatic pressure, that is trying to force the water out, and oncotic pressure is trying to hold the water. And it's a balance between these two pressure, which will be telling whether there will be edema or not. If the oncotic pressure, plasma protein is less, or oncotic pressure is less than the hydrostatic pressure, what will happen? The water will move out of the capillary and there will be edema. So same thing here. Here two opposite force. One is the inside we are having the glycoprotein, which is giving the oncotic pressure, and intradiscal pressure, which is trying to force the water out. And it is a balance between these two. If the oncotic pressure is more, it will be holding the water. If the oncotic pressure is less, water will be coming out. And this is what happens in an elderly versus young. In a young, lots of chondrocyte. So, and that I forgot to mention, that these chondrocyte cells inside, they are laying down, they are producing the glycoprotein molecules. So in the younger, the lot of number of the chondrocytes, the lot of glycoproteins, and in the younger, if you're having an MRI, you'll be seeing that it looks well hydrated. Why well hydrated? Because a lot of glycoprotein molecules are there. But in an elderly, the chondrocyte cells number will decrease, less glycoprotein molecule, so less water. In an elderly, if you're having an MRI, you will see that the most of the disc is dehydrated, less water. So this condition is known as aging of the disc. So aging of the disc is what? Aging of the disc is dehydration of the disc. But it is not the degeneration. What is degeneration? Degeneration takes place in the inner layer of the annulus. Why the inner layer? Why not outer layer? Because inner layer don't have any blood supply. Outer layer have a very thick blood supply. So it is always starts with the inner layer. And if it is degenerated, what will happen? Nucleus pulposus will start leaking. Okay? And if nucleus pulposus start leaking, what the body will do? Body will try to repair that leaking. So how to repair that? By neovascularization. Blood vessels will grow inside. And very important is, we are having sympathetic fibers here accompanying the blood vessels. So that sympathetic fibers joins the Rami communicants fibers, gray Rami communicants fibers. We join the sympathetic chain and which goes up, taking the signal from this disc. So that is the major nerve supply of the disc. We are having the synovertebral nerve also, which is the part of the somatic nerve. But 90% of the nerve in the disc is sympathetic nerve. So this blood vessel, when it is growing, sympathetic nerves also grows in with the blood vessels and they are meeting. Once they will be meeting with the nucleus pulposus, then what will happen? There will be inflammatory reaction. Why? Because these aggregate glycoprotein molecules, they are separated from the body's immune system by long distance. The blood vessels are here, immune system is active here, and nucleus pulposus is there. So it is not coming in contact with the immune system. So when the first time the glycoprotein molecules comes in contact with the immune system, the body thinks it as a foreign material. So there will be inflammation. And that inflammation will be spreading to the sympathetic fibers as well. So these sympathetic fibers get inflamed and they get sensitized, and any rise of the disc pressure will produce pain. And this condition is known as discogenic back pain. Internal disc disruption is another term. Radiologically, we'll be getting annular tear, nucleus pulposus, causing the inflammation within the layers of the annulus. So this patient will present as a diffuse back pain. Why diffuse back pain? Because this pain is mediated by the sympathetic fibers. If the pain is mediated by the sympathetic fibers, then the pain will be diffuse. Because sympathetic fibers don't have any dermatomal distribution. Somatic nerve has a dermatomal distribution, but sympathetic fibers don't have a dermatomal distribution. I'll be talking about the sympathetic anatomy in our, the sixth module. That time I'll be discussing about this detail, that what is the clinical feature if a pain is mediated by the sympathetic fibers versus if the pain is mediated by the somatic fibers. So just now remember for now that if the pain is mediated by the sympathetic fibers, pain will be diffuse, not well localized. But this will be predominantly present at the back pain, and this pain will be aggravated on sitting. No radicular pain in the leg. Why aggravated on sitting? Because sitting causes a rise of the interdiscal pressure. I already mentioned it. Standing, less interdiscal pressure, so less pain. Lying down, still less interdiscal pressure, so pain will be relieved on lying down. So this is the typical presentation of the internal disc disruption. Okay, so sorry, let me erase these drawings. Okay, now this is a Dallas classification. So Dallas classification of disc degeneration. So grade 0 means this is normal. Grade 1, this is nucleus pulposus is leaked only inner 1/3. Grade 2, it is coming up to the middle 1/3. Grade 3, it is coming up to the outer, but there is no leakage outside, or there is no circumferential spread, only up to the outer 1/3 without any leakage. Grade 4 is there is a circumferential spread also. And grade 5, when it is leaked outside. So these are the 5 grades of disc degeneration. So disc degeneration means, always remember, that it is the degeneration of the inner layer of the annulus, and nucleus pulposus starts coming towards the periphery. So this is what is your the disc degeneration. Now a quiz. So answer this quiz. Which Dallas grade disc is likely to be responsible for the discogenic back pain? Which grade? Grade 1, grade 2, 3, 4, 5. Which one? I'll be answering why. But first, let me see what are you thinking. Which is responsible for the discogenic back pain? So majority of you have answered grade 5, but no. You see, the grade 5 is what? Grade 5 means nucleus pulposus is leaked and coming outside. So once it is leaked, all the layer, then what will happen? Interdiscal pressure will be what? Less. Even if you are sitting, interdiscal pressure will not rise. So as I mentioned, that what is the mechanism of the back pain in discogenic back pain? It is that the sympathetic nerves has grown in, sympathetic nerve is inflamed, and now any rise of interdiscal pressure is going to cause pain. That's why sitting is painful. So if it is Dallas grade 5, then what? Then interdiscal pressure cannot go high because it is leakage is there. So Dallas grade 5 is rarely associated with the discogenic back pain. It is a grade 2 or grade 3. Most commonly, it is the grade 3, but not grade 5. Okay. So now, if the disc is as a pain generator, so again, this is very important. And one request to all of you, please don't scratch. If you want to answer when you are having the quiz, when you are answering, that time you on your mobile, you put it on the color code. Means it is question, every question has a color code. So in that color, you press it and your answer will be registered here. But don't put any tick or anything here. On your mobile itself, you press on the color code and you just answer your question. Okay. So if the disc is as a pain generator, one clinical entity is what? That is your internal disc disruption. As I mentioned, what is it? That means nucleus pulposus is leaking and sympathetic nerve is growing and their sympathetic fibers are inflamed. And if there is a rise of the interdiscal pressure, then that nerve is creating pain. And now this is the clear MI communicants through which the pain will be going, and it is going above and we are feeling pain. And here the pain generators are what? The sympathetic nerves within the disc. Now what is disc prolapse then? This is not disc prolapse. What is disc prolapse? Disc prolapse is if the nucleus pulposus is leaked or if it is bulged so much that this somatic nerve root is getting compressed, then there will be prolapsed disc symptom. What is that prolapsed disc symptoms? That the patient will be having the radiating pain to the leg, and that is prolapsed disc. And the third one is what? Canal stenosis. What is it? Canal stenosis, as I mentioned, that if the disc height is less because of the degeneration of the annulus, two vertebral body will be coming closer. If the two vertebral body comes closer, what will happen to the lamina? Two lamina will be coming closer, and in between there was ligament and flavum. So ligament and flavum will be folded and it will be protruding anteriorly. So this ligament and flavum, this is known as ligament and flavum hypertrophy. Though ligament and flavum hypertrophy is a misnomer, but still that is the major contribution for the canal stenosis. And also there will be some bulging disc from anteriorly. And sometimes there will be facet joint hypertrophy from the posterolaterally. So these three components normally contributes the narrowing of the central curve. What will happen? The effective diameter where our nerve roots are there, so they will be getting compressed. And the blood vessels, which is supplying the nerve roots, they are most vulnerable structure. So the blood vessels will be narrowed. If the blood vessel is narrowed, what is important? That when the patient is sitting, the patient will be having less pain because of two reasons. One is they need less oxygen. So blood vessel is partially compressed, but still the blood circulation is there. Because the nerves needs less oxygen, that much of requirement will be fulfilled. But when they are walking, they need more oxygen. That need will not be fulfilled. So there will be relative ischemia. Another reason why the patient is comfortable on sitting. See, when you are sitting, what happens? You are bending forward. So if you are bending forward, what will happen? So these two lamina will be getting separated. So you think that I am bending the spine anteriorly. So the two lamina will be getting separated. So this ligament and flavum, which was folded anteriorly, will now be stretched. If it is stretched, the canal diameter will be increased. So remember, this is a rule that in the lumbar canal area, the canal diameter will be increased if somebody is flexing forward. And that is the reason why the canal stenosis symptoms will be relieved on flexing forward or on sitting. So a disc degeneration, three ways it can present. One is internal disc disruption causing the back pain. Second is prolapsed disc, where the pain generator is the nerve root and they causes the radiating leg pain. And third one, which causes the ischemia of the nerve because of the compression of the blood vessels, they present with claudication. We call it neurogenic claudication, means the nerve is becoming ischemic. So what will be the clinical features? Not only pain, patient will be talking about the numbness, weakness, heaviness, this kind of neurogenic features will be there. And this is known as neurogenic claudication. So three way to clinical way for the presentation. Internal disc disruption producing back pain, disc prolapse producing radicular leg pain, canal stenosis producing the neurogenic, canal stenosis producing the neurogenic claudication. Okay. So now let us go to the next slide. Sorry, let me erase this part. Okay. So these are the three presentations. Internal disc disruption causes back pain on sitting. Prolapse disc producing leg pain. But this leg pain is relieved on sitting, lying down. Why? Because when you sit, we flex hip and knee. If knee and hip is flexed, then the nerve root is relaxed. So the less pain. But on standing, what happens? Extension of the hip and the knee, particularly the knee extension, causes the stretching of the nerve root. And that is the reason why the pain will be increased on standing or walking. And in canal stenosis, nothing, no symptoms on sitting, only there will be pain on walking. That is known as neurogenic claudication. So these are the three different ways a prolapsed disc can present. So now one very important MCQ. In elderly, more than 80% will have disc bulge who don't have any back pain. Is it true or false? So majority of you have answered right. Yes. Once we're growing older, the disc bulge is very common. And those who never ever had any back pain, understand this percentage, 80%. And I'll be sharing on study. So this study was published in 2015, and this was a meta-analysis. Meta-analysis, when several published article was gathered together, and the data was extracted, and a new data. So the data was extracted from 3,110 asymptomatic individuals. So MRI of these asymptomatic individuals, what was the findings? So the MRI, this degeneration was seen 37% in 20s and 96% in 80s. Disc bulge, 30% in 20s and gradually is increased to 84% in 80s. Disc protrusion, 29% in 20s and 43% in 80s. Annular tear, 19% in 20s and 29% in 80s. So what should we learn from this data? That if we are making our decision based only on MRI, then we'll be making mistake in 80% situation. Understood? So that means the clinical feature is the very, very important part. You have to understand that this protrusion is there. If the patient is producing with the back pain, so you should not be calling it as a prolapse disc. So we'll be coming, next class, we'll be talking about the clinical features as well, the clinical evaluation as well. But right now you understand that the diagnosis should not be only on MRI. MRI and clinical features must be matching. If you are relying too much on MRI, then we'll be making mistake in more than 50% situation at any age group. So remember these things. This is a very, very important slide. And now, even after 2015, still lot of more data are there available, which is supporting this same, the findings earlier. That means more than 50% patients have the asymptomatic prolapse disc. They don't need any treatment unless there is any red flag or unless it is becoming symptomatic. You have to identify other source of the pain generators. The pains, suppose somebody is having a back pain radiating to the leg. It's not only the disc prolapse which is responsible for that. There may be so many other structures, so many other pain generators, which also can cause back pain with the leg pain radiation. So you have to find out those pain generators as well. First clinically, and then matching with the MRI. And still, if there is a confusion, we can go for the diagnostic blocks. Okay, another quiz. Incidence of the back pain where the pain generator is not the disc. As you already mentioned earlier, disc is the commonest. But what percentage of the back pain is because of the disc, and what percentage of the the pain, back pain, is not because of the disc? So right answer is 60 to 75% back pain are not because of the disc. That means we have to evaluate the back pain properly to understand where is the pain generator. Disc might be the commonest, but there are a lot of other structures which might be responsible for the back pain. So let us see what are these structures. Very important is your facet. So facet joint, if we are identifying facet joint as a source of the back pain, then the commonest one is your disc degeneration. Then it can be inflammation, it can be trauma, as I already mentioned. That the other few things important, that can be responsible for the. Okay, somebody is putting the ticks there. So as I told you, please answer it through the mobile, through the kahoot.it, www.kahoot.it, and then you log in with the number, the pin number, game pin, and then you answer these questions. Otherwise, your questions will not be registered. If you are putting a tick here, that your right question is not registered here. Okay, so the facet joint is a very, very important source of the back pain. So the thing is, if the facet joint is the source of the back pain, then answer this quiz. That how many percentage of the back pain is because of the painful facet joint? That means what is the contribution of the facet? The disc already I mentioned, it is something around 25 to 30%. But what is the percentage of facet joint as a cause of the back pain? The answer is every fourth or fifth patient suffering from back pain is because of the facet. So it is the second most common reason for the back pain. And it can also mimic prolapse disc because facet joint pain can be radiating to the legs. So these are the facet joints. So facet joint is forming the posterior boundary of the spinal canal, posterolaterally, and they are also taking the load. How much of the load, body's load is taken by the transfer by the facet joint? It is approximately 20 to 25% in the lumbar area. So major load is transferred by the disc and the vertebral body, but in the erect posture, facet joint also significantly contributing. But if you are extending, if you are bending, then the load of the fascia joint increases. So how to increase the load of the fascia joint and how to decrease the load of the fascia joint? If you understand this, then you'll be able to understand that which posture is going to increase facet pain, which posture is going to reduce the facet pain. So first is how to load the fascia joint. So fascia joint is the pivot for three important movements. One is extension, lateral bending, and rotation. So these three movements, extension, lateral bending, and rotation. So if these three movements are done, then the fascial joint loaded is more and the pain will be more. So clinically also you can do this test. You can ask the patient to extend, you can rotate and lateral bending. And if the pain is aggravated, then you understand this might be facet joint. And when you are sitting, what do you do? We bend forward. Bend forward means the load will be coming here, not here. So this will be unloaded. So pain will be relieved. That means sitting will be reducing the pain in the facet joint. Understand this. Sitting causes decrease of the pain on the facet joint pain. Extension, rotation, bending, lateral bending increases the facet pain. Here, the facet pain, normally, if it is alone, then it is not associated with the neurodeficit. Pain might be referred, but that pain will be non-dermatomal, but pain will be decreased on walking. Unlike that of the prolapse disc, pain will be decreased on walking. So understand these few clinical features. What are these clinical features? Number one is pain will be less or no pain on sitting. Pain will be increased on extension and lateral bending and rotation. Pain will be decreased on walking. There will be no neurodeficits if it is only facet joint. And the pain will be referred to the leg in a non-dermatomal fashion. Non-dermatomal means, you remember the dermatomes? So it will not be following any dermatome. In the prolapse disc, the radiation will be dermatomal. But here, it will be non-dermatomal radiation to the leg. So this is a very important clinical feature for the facet pain. Now come to the another important cause, sacroiliac joint. So if the sacroiliac joint is the cause of the pain, then if that is a pain generator, where answer is SI joint, then why answer are similar. It can be degenerative, it can be inflammatory, it can be traumatic, it can be malignancy, and sometimes it can be even tubercular infection as well. So infection also another cause, but that is rare cause. Now come to this quiz. So prevalence of the SI joint pain as a cause of the lower back pain. Okay, majority of you have answered right, 15 to 40%. In the younger population, it is less. Elderly, it is more. Younger, it is mostly inflammatory because of the ankylosing spondylitis. Older, it is mostly because of the degenerative conditions. So, if the facet joint is the cause of the pain, what will the clinical features? They will present as a buttock pain or lower back pain, mostly the buttock pain, and well localized. Basically, with the finger will be telling, here is my pain over the joint. So that is the most important clinical feature. Pain will be also increasing on sitting. Why? Because sitting loads the facet, the SI joint, but also on prolonged standing, it will be relieved on standing or walking, but on prolonged standing again or prolonged walking, again there will be load on the SI joint. So mild walking, standing for some time is not going to increase the pain, decrease the pain, because it's a joint pain. Any joint pain, the pain will be decreased initial part of walking. Prolonged standing, because again on the load on the SI joint, pain will be increased and there will be no neurodeficits. Pain might be referred in a non-dermatomal fashion, like in facet joint in the legs, and there will be no dermatomal pattern. Most common referred area is your back of the thigh. So these are the clinical features if the sacroiliac joint is the source of the pain. Muscles, again, muscle is one of the very common cause. And as I was mentioning, the newer researchers are telling the incidence of the muscle pain, myofascial pain, might be little more than what was there in the earlier studies. So why the muscles can be source of pain? It can be because of the repetitive stress injury. It can be trauma. That means, sometimes you're sitting all the time in the same posture. So the muscles are continuously under stress, or there is some trauma, or there is some prolonged muscle spasm because of some condition. Suppose there is a facet joint inflammation and there is a back pain. So what my body will try? Body will try to reduce my pain. How to reduce that pain? By sprinting. Body's own sprinting system is what? By doing a muscle spasm, limiting the movement, my pain will be reduced. So it's very common findings on the X-ray that lumbar lordosis is corrected, muscle spasm is there. So that is not the cause, that is the effect. But if this muscle spasm continues for the longer time, so there might be secondary myofascial pain. So myofascial pain will be taking one class towards the end. So myofascial pain is one of the common cause of the anywhere pain, but it can be secondary to some other pathologies. Myofascial pain, commonest myofascial pain is secondary to some other cause. So anything which is causing the prolonged muscle spasm can lead to the secondary myofascial pain. Malignancy also can cause the secondary myofascial pain. So when the lots of muscles are there, and here in this, the psoas muscle, quadratus, through which the lumbar plexus comes. So sometimes it can mimic the lumbar radicular pain. So then piriformis can also mimic the sciatica. And there are a few other muscles are also there, gemelli muscles, the gluteus muscles. So all these can be the source of the pain. So myofascial pain, as I told you, it was ignored earlier as the causes. It was ranked as a fourth common cause of the back pain. But nowadays, some newer researchers are telling that it might be. Still now, the research is telling it is not the commonest cause. But recent research is telling might be the statistics might be changed in the near future with more and more research. Now, answer this quiz. Which myofascial pain or myofascial pain of which muscle can mimic a sciatica, which is known as pseudo-sciatica? Multifidus, gluteus maximus, gluteus medius, piriformis. It mimics sciatica. And many of times, operation has been done because of the misdiagnosis. Yes, piriformis. Why? Because sciatic nerve lies just in front of the piriformis muscle. So if there is a piriformis myofascial pain, sciatic nerve might be getting compressed, and we might be thinking that this pain is because of the disc prolapse. That is one of the common misdiagnoses. So the piriformis syndrome should be one of the very important differential diagnoses whenever you are thinking of the prolapse disc. Next is your ligament. So some ligaments are there, interspinous, supraspinous, the sacroiliac, different ligaments are there, which can be, there might be sprain, injury, or enthesitis. What is enthesitis? Enthesitis is the, the inflammatory edema because of the, mostly because of the autoimmune disease, where the tendons or ligaments are getting attached to the. So that part is known as enthesis, and enthesitis is an inflammatory condition. So this can, happen, and that is one of the, no, I should not be causing as a very common cause, but it should be also coming in your differential diagnosis. Then your vertebral body. Vertebral body also can be a very important cause. Earlier, vertebral body was ignored in our earlier researches, but nowadays the innervations pattern of the vertebral bodies are also similar. So if there is any inflammation of the vertebral body, fracture in the vertebral body, fracture is not that common because of the trauma, because of the malignancy, because of the inflammatory conditions. So it can mimic the vertebrogenic pain. It can mimic the discogenic pain. So discogenic pain and vertebrogenic pain might be having the similar kind of the clinical features. And the vertebral body is nowadays is one of the important interest. So newer researchers are telling that vertebral body should not be ignored when we are evaluating the back pain. Then some of the bursas are there, like, trochanteric bursa, the ischio-gluteal bursa. So sometimes they are getting inflamed in the autoimmune disease, and this inflammation can cause the bursitis, and that should be also considered as important pain generators. Then, as I mentioned earlier, never ever forget hip joint examinations. Hip joint can also causes the buttock pain radiating down to the leg, and it can be mimicking the radicular pain. It can be mimicking the prolapsed disc. I have, in my practice life, I have seen several such cases where the hip joint was ignored. Complaint was buttock pain going to the leg. History of trauma was very trivial trauma. Sometimes it was because of the secondary fracture, and the fracture was there, which was misdiagnosed with a prolapsed disc, because MRI of the lumbosacral spine was done, not hip joint was ignored, and on the lumbosacral spine, the asymptomatic prolapsed disc, which is very common, was found, and everybody was pointing that asymptomatic prolapsed disc, completely ignoring the hip joint. So never ever ignore hip joint. You must be always examining the hip whenever a patient is complaining of the back pain, buttock pain radiating down to the leg. So coming to the end of today's this evaluation session, we have discussed about the causes and its clinical features. Next class, we'll be talking about the red flags, history, clinical examinations, and the third module will be talking about the different evaluation. So now one quiz. This is for the next class, but just for today. Which one of these is a red flag? Excruciating pain, mild numbness, unable to hold urine, severe trauma. We'll be discussing this in more detail in the next class. But just today, little bit of interest. What are going to discuss in the next class? Unable to hold urine is not a red flag. It is the retention of urine is the red flag. Severe trauma is a red flag. Okay, remember, retention of urine is a red flag. Excruciating pain is not a red flag. Mild numbness is not a red flag. Okay, we'll be discussing in detail in the next class. Now, quick recapitulation of what we have discussed today. What increases pain in the prolapsed disc? Lying down, sitting erect, standing, sitting and leaning forward. Which increases the pain in prolapsed disc? Sitting and leaning forward, no. Sitting and leaning forward is not going to stress the nerve root. Nerve root will stressed on sitting, the standing. Standing, nerve root will be stressed. So that is the right answer. Lying down, sitting is not going to stress the nerve root. So nerve root will be stressed on standing. If you are flexing the knee is no longer, the nerve root is no longer stressed. So in prolapsed disc, standing or even lying down straight is going to increase your pain. Sitting reduces the pain. Next question. True or false question. Facet pain increases on walking. Is it true or false? So majority of you have answered right. So facet pain decreases on sitting. Facet pain decreases on walking. What will increase the facet pain? Extension, rotation, lateral bending. They are going to increase the facet pain. Okay. Which is the most commonly affected by spondyloarthropathies? Which joint, which structure is most commonly? Spondyloarthropathy means a group of inflammatory arthropathies, which includes ankylosing spondylitis, psoriatic arthritis, reactive arthropathies. So majority answered right. Sacroiliac joint is most commonly involved in spondyloarthropathies. Next common is your facet joint, but most common is your sacroiliac joint. And as I mentioned, sacroiliac joint pain in the younger population is most commonly because of the spondyloarthropathies. So what is spondyloarthropathies? Spondyloarthropathy is a group of disease. What are this group of disease? Ankylosing spondylitis, reactive arthritis, psoriatic arthritis. So these are together is your spondyloarthropathies. What is a clinical feature of cranial stenosis? Leg pain on standing, leg pain on sitting, back pain on walking, back pain on sitting, leg pain on walking. Which is the clinical feature of the canal stenosis? Okay. Again, majority answered right. So we told the claudication. Sitting, no back pain, no leg pain. That is the feature of the canal stenosis. And why I told. One is canal diameter increases on sitting because of the stretching of the ligament and flabum. And second is nerve needs less oxygen on sitting. So walking will be producing leg pain, and that is the main feature of the canal stenosis patient. Again, true or false? Bursa pain is commonly because of the inflammation. Is it true or false? Okay, so majority answer true. Bursa pain is most commonly because of the inflammation. Sometimes it is because of the degeneration, but most commonly it is because of the inflammation. True or false? SI joint pain increases on sitting. Is it true or false? Okay, again, majority answered right. So sitting will increase the sacroiliac joint pain, and prolonged standing will also increasing the pain. Otherwise, standing from sitting is going to reduce the sacroiliac joint pain. Sitting increases. Remember this rule. Again, true or false? Facet pain is most commonly because of the degeneration. Is it true or is it false? Most commonly because of the degeneration. Sometimes it is because of the inflammation, but that is not the most common cause. That is second most common cause. So what increases pain in facet joint? Walking, lying down, lateral bending, sitting. So lateral bending. Lying down, walking, sitting, all are going to reduce the facet pain. Next, true or false? Muscle spasm causes back pain. Is it true or false? Yes. And sometimes muscle spasm, continuous muscle spasm can cause secondary myofascial pain, what I mentioned already. So two more questions. What is the most common clinical feature of sacroiliac joint pain? Walking pain, neurodeficits, leg pain, buttock pain. So obviously, buttock pain. Buttock pain is the most common. And as I told you, patient will be able to pinpoint the exact area of the bone. Okay, so now the last is Kahoot presentation is better than the conventional presentations like I presented in the first class. Okay, so unanimously, not everybody is agreeing that it will be on the Kahoot, but majority. So some of the lectures will be on Kahoot. Okay, so if you are having any quick questions regarding the whatever I have discussed today, you can. Okay, let us see the results who scored maximum. So who is PM? So Bindu scored highest, then PM, then Gigi, and Najis and Nuna. Who are those? I don't know. But anyway, so this was just for fun, and I hope you enjoyed it. And I'll be taking a small break. If you're having any questions, quick question, you can ask me. And then I'll be coming up with the live demonstrations of the sonor anatomy, the fluid anatomy, and the demonstration of the facet joint injection and your transforaminal on the mannequin. Okay. Any questions, quick questions if you wish to ask?
So please, can you repeat in what position is the disc prolapse pain maximum?
Disc prolapse pain position will be maximum on standing and also on walking and also on lying down straight. If the knee is straight, then the nerve root is stretched. So pain will be more. So disc prolapse pain will be aggravated on stretching the nerve root. That is how on the straight leg rising test becomes positive, stretching the nerve root. So the nerve root can be stretched with the knee straight. Stretching down, SLR test can also be done on sitting posture. All these I'll be talking on the next class. But just remember that if you're stretching the nerve root on standing or walking, then the pain will be increasing. Sitting reduces the pain on prolapse disc. Okay?
Okay. Okay.
So,
What is the most common cause of pain in young adults, sir?
Can I repeat the question? I couldn't hear. Hello, Jitendra.
Sir, in both disc prolapse and canal stenosis, the pain is relieved on sitting.
Right.
Then how to differentiate between the two?
Differentiation is difficult, but still one of the very important differentiation is that the claudication. That means patient will not be having any rest pain. On the some rest pain might be there in the prolapse disc. And the canal stenosis, most of the times there will be no rest pain. Every pain will be coming after some times, after walking. But again, there is overlapping. If the prolapse disc is there, in fact, there is narrowing also. So the most of the times, these two are coexisting together.
Okay,
Sir,
sir.
what happens to the pain in prolapse disc if the patient is bending forward?
If the patient is bending forward, that depends on whether the patient is having the canal stenosis symptoms. If the canal stenosis symptoms is there, bending forward will be increasing the canal diameter and the patient's pain will be reduced. So bending forward will be increasing the canal diameter. And second thing is, what is the position of your knee? That is the very important part. If the knee is extended, then the pain will be increasing. That means if you are bending forward on standing and bending forward, pain will be increasing. But if you are sitting and bending forward, then pain will not increase. Pain will decrease because your knee is in the flexed condition.
Okay, sir. Thank you.
Sir, good evening, sir. I have a question, sir.
Yes.
Sir, if a patient with pain, so if patient presents with pain in periphery, like enthesitis type of symptoms, and on examination they found to have Fabers positive and tenderness, and all the SI joint test positive, sir, will we diagnose them as spondyloarthritis or we will do further evaluation, sir? Clinically,
Yes,
sir?
most likely it will be spondyloarthritis. Okay, so let us start these things. Give me 5 minutes break. So time is now 7:15. So I'll be back by 7:20. Can you
So
hear me? Can you hear me?
yes, sir.
Yes, sir.
You're audible,
Yes, sir.
sir. Audible.
Okay. So first part is quickly I'll be showing the on the 3D anatomy that what we are going to do, and then I'll be coming into the real patient. So first, this is the lumbosacral spine. Remember that one of the very important limitations of the CM guided procedure is we are unable to see any nerve, we are unable to see any muscles, other blood vessels. So you have to understand, we have to know the anatomy very nicely. You have to understand that what are the different structures present at different areas, and you have to put your needle accordingly. So the very important part is the first part is your how to place your CM. So the CM, when I'll be talking about the fluid anatomy, that time I'll be talking more. So just if you remember, first we start with the AP view. If you're looking at the AP view, we'll be seeing this picture. And the vertebral body and the lamina and this inferior articular process, they'll be overlapped. And we have to identify each and every structures. I'll be demonstrating that on the live fluoro. So here first remember that we always take in the first AP view, and then we make it the craniocaudal tilt, which is called squaring. And then we'll be going for the Scottish dog image, oblique image. Again, what exactly is it? I'll be showing you on the real procedures. But just try to understand what is the target for our facet joint. So facet joint, this is the exiting nerve root. Okay? The exiting nerve root gets divided into the ventral rami and the dorsal rami. These are the rami communicate sympathetic fibers. So ventral rami and dorsal rami. So dorsal rami has 3 branches. Lateral, here the one branch is not so. So lateral, intermediate, and medial. This medial branch is our target for the facet joint. And it lies, you see, where? Superior articular process and transverse process junction. So I have to come at this junction for doing the medial branch block. Medial branch block, each facet joint is supplied by one medial branch block, which is coming from below. Another is coming from above. So each facet joint, suppose this facet joint, L4-5 facet joint, I have to block 2 medial branch. One is this one. This is the L4 medial branch coming from the L4 nerve root, and this is from the L3 level. So L4-5 facet joint is innervated by one from above, that means from the L3 level, and one from below, that is from L4 level. So this is the joint innervated. So this medial branch also supplies the multifidus muscle and supplies the midline structures, the supra and interspinous ligament, and also little bit of skin area in these areas. So out of these dorsal rami branches, the medial branch is most thick, you can see. It supplies the multifidus muscle as well. The second or the intermediate branch, it supplies the longissimus muscle. You remember the 3 erector spinae muscles are there. Most medial is multifidus, then your longissimus, and then is your iliocostalis. Iliocostalis is supplied by this lateral branch. So these are all dorsal rami branches. So our target for the medial branch will be this one for the facet joint pain. Or we can go intra-articular also here in this area. In the intra-articular, you see these 2 surfaces are not plane. It's not, one surface is the concave, the superior articular process is concave, and this is your convex. So you can never go through and through in the lumbar facet areas. You can only inject only the part or in the mouth or in the periarticular area. So this is for the facet joint. Now another important thing is for the disc. So, sorry, for the foramen. So the foramen, you understand that this is the neural foramen, and neural foramen can be divided into 2 triangles. One line, imaginary line, is drawn below the pedicle here. One along this facet joint line. One along this transverse process, and another on the lateral sides. So this is a square, and this square is divided into 2 angles by this exiting nerve root. By this exiting nerve root is dividing into 2 triangles. This triangle is known as the safe triangle, though it is not safe because the blood vessels are there which is supplying the nerve root. But still, conventionally, it was known as a safe triangle. And if you are injecting here close to this exiting nerve root, then this is also called the nerve root, selective nerve root injection, nerve root sleeve injection, subpedicular approach, because this is the pedicle and your needle is just below the pedicle, subpedicular approach, or supraneural approach because you are above the nerve. So these all are the name for this procedure. So this is your transforaminal epidural. This is the foramen. Foramen is bounded above by one pedicle, below by another pedicle, medially by above by inferior articular process, below by the superior articular process. So this is the neural foramen. So this neural foramen is divided by the exiting nerve root into two triangles. One is shaped triangle above. So the shaped triangle approach is the conventional way to do the transforaminal epidural. But nowadays, we prefer to go below this. This triangle is known as the Cambine's triangle. So this Cambine's triangle, this area, I can go inside the disc, intraneural approach. And here, the major blood vessel is not there. Though this is looking empty, but there is major blood vessels, which is not seen on the CM. So this is more risky than this. So this is intraneural or the Cambine's triangle approach. So today I'll be showing you 4 procedures. One is intra-articular facet joint. One is medial branch block for placement will be here. Another is your supraneural approach of the transforaminal. Another is your intraneural approach of the transforaminal. Okay. So these are the few procedures what I'll be showing you today. And now let us come to the okay, I hope all of you can see my, the CM picture and also the mannequin. This is the mannequin. This is the caudal end. This is the cranial end. And you can see the CM also. You can see the CM, how the position of the CM will be changed in the different positions. So first, we are having an AP image. AP image means patient is lying prone. This is the back side. This is the abdomen. And the X-ray tube is below, and this is the II. So that means the CM, the radiation, the X-ray is coming from below, from anterior abdomen side to the back side. And this AP image is the most important image. Here the radiation will be minimal. Why? Because when the radiation is coming, some of the radiation is penetrating and some are reflecting. So if it is coming from below, what will happen? It will be reflecting down towards the floor. But if suppose if you are keeping the X-ray tube above and the II below, what will happen? X-ray will be coming here and will be all scattered to us, causing a lot of radiation. So never ever keep II below. Always keep II above and the X-ray tube below. So AP view is the best view for the spine procedures. Oblique, if you're making it oblique on the one side, that is oblique view. And lateral, if you're taking it to the other side, then also radiation will be very, very high. But still, because this image is a 2D image, and in reality it is a 3D, so you need to see it at a different angle as well as the lateral view. Then only you can understand the depth. So the depth, direction, depth. So you have to move your CM in different angle to understand where exactly is your needle. So this is the very basics of the radiation safety as well. Try to reduce the radiation hazard by putting your X-ray tube below. Another is always put this kind of lead apron, and whenever you are giving the short X-ray, then you try to go away. Then what will happen? If you are increasing the distance, the radiation hazard will be minimized by square of the increase in the distance. That means your radiation hazard, if this is 1, it will be the square, the 2 millimeter, so the 2 foot and 4 foot. So we are reducing the radiation hazard by square of that. So that means whenever you are giving the shot, don't come stand close to your X-ray tube, go little away and have the X-ray shot. So the distance, this the protective lead jackets, sometimes protective goggles, protective gloves, lead gloves, and the position of the CM. This is how we are going to minimize the radiation hazard. Okay, so the first step of doing an lumbosacral area is to have an AP image. So you are having the AP image here. So in this AP image, what you can see here, one is your spinous process. So the spinous process is seen as a tunnel vision because spinous process is like this projected. So if you're having an X-ray image coming like this, we'll be seeing spinous process in a very small area. The pedicle is a pillar. but you are not able to see the pillar. You are seeing only the tunnel vision of the pillar. Like say, for example, this is a pane. If X-ray is coming like this, I'll be seeing it as a rod. But if X-ray is coming like this, then I'll be seeing it is a small circle. Same way, I'm seeing this as a circle. Why? Because the pedicle is like this. So little oblique, but still in the AP view, pedicle will be looking like a circular structures. Spinous process will be seen as a, the elliptical structures. And then transverse process. Transverse process will be seen nicely because we are perpendicularly over this spinous process. Then you can see this is the lamina, this is the inferior process, superior process. So this all we'll see. But one very important thing to understand here that because our spine is curved, so and your X-ray is diverging, X-ray beam is not falling perpendicular to each structures. So here you see, I can see here the one line, almost one line. But here you can see two lines. Why? Because here X-ray beam is not falling perpendicular. If it is falling perpendicular, this one border and another border will be merging together. So this is known as squaring because it looks like a square. This is not squared. So first step is your true AP view. True AP view means the distance between the two pedicle, from the midline. So this will be same. That means this is a true AP. Next step is your making it end plate parallel like this. So these are the two important steps. So first step is true AP. True AP means the distance from the, because sometimes patient may be tilted and you may not be having a true AP. So true AP means your distance from the spinous process and true pedicle will be equal. And next step will be making end plate parallel. So if I'm trying to do the procedure at this level, I need not make a craniocaudal tilt. But if I want to do the procedure here at this level, then I need to make a cranial tilt. I'm making a cranial tilt here, not a tilt. Now you see, now you see, so now the end plate at this level, at L4-5 level, is now becoming, the single line. So I'm ready to do this procedure at this level also. So next step will be here for the lumbosacral procedure is making it oblique. So I'll be making it oblique. If you're making it oblique, what is happening? You see, one thing is this transverse process is becoming same-sided transverse is becoming shorter. Other side transverse process is becoming longer. Lamina is becoming larger. You see, same side lamina is becoming larger. And you can imagine a nice Scottish dog here. So you see, this is looking like a Scottish dog. So this is the face, this is the ear, this is the nose, this is the neck, this is the front leg, this is the body, and this is the hind leg. This is the tail of the Scottish dog. So you can imagine a Scottish dog. And at this position, we are ready to do several procedures. What are these procedures? If I'm putting my needle here, facet joint is opened up. I can put the facet joint injection intra-articular. When I'm putting my needle here, it is at the junction of the transverse process and the superior articular process. This is the superior articular process, the transverse process. At this junction, or eye of the Scottish dog, the medial branch. So now the nerve root is coming like this. So if I'm putting my needle there, so this will be your intrapedicular or the supraneural approach, transforaminal epidural. And if I'm putting my needle here, just lateral to the superior articular process, so it will be my Cambine's triangle approach. So these are the 4 procedures I can do in this position, in the Scottish dog image. So Scottish dog image is very, very important image position for the lumbosacral areas. So I'll be putting all the needles, all 4 needles together, and then I'll be checking by the lateral views. So here, I'm not measuring anything, how much distance away from the midline. So this is all radiologically, determined. So what I'm doing, when I'm getting a very good Scottish dog image, then I am putting my radiological marker there. So you see, facet joint has opened up nicely. So this procedure is for the intra-articular facet joint. And another very important concept is that we will be making it a tunnel vision. What is tunnel vision? So the same, you see, my needle is not seen as a line. My needle is seen as a dot. No, it's a dot. So this is known as tunnel vision. As if you are looking a tunnel through one end and you are seeing a circular things. That is your tunnel vision. So at this tunnel vision is very, very important for the procedures in the lumbosacral areas. So the tunnel vision, I'll be going into the joint. Okay, I'm in the joint. I'm hitting the bone there and I'm in the joint. So this is for the intra-articular facet joint. Okay. Next needle I'll be putting it for the medial branch. Picture. And then I'll be going lateral together so that I'll be saving time. Picture. Again by the tunnel vision at the eye of the Scottish dog. Okay. So I'm hitting there in the upper outer quadrant of the pedicle in tunnel vision again. And I'm touching the bone there. I'll be checking by the lateral view. Checking if by lateral view is very, very important to tell that I am in the right position or not. Then I'll be putting one below the pedicle. Picture. Picture. So this is for the subpedicular approach. But I'll be putting it further once because there is nerve root. If I'm advancing the needle, I might be hitting the nerve root. So further advancement I'll be doing by the lateral view to see my aim will be in the posterior border of the boundary of the neural foramen. Okay, my fourth needle will be there, just lateral to the superior articular process. Picture. Picture. Okay, I'll be going by the lateral view. All are in the tunnel. This is not in the tunnel vision. I will be making tunnel vision, proper tunnel vision. Okay, now I'll be going by the lateral view. And further adjustment or advancement, I'll be doing it on the lateral view. So very important to understand the structures in the lateral view. So how we can see here, this is your vertebral body. This is the pedicle, pillar. Transverse process is not seen now because transverse process is now seen as a tunnel vision. This is the transverse process. Then this is the joint, facet joint. Whole is facet joint. This is the foramen. Foramen boundary I told. What is the boundary of the foramen? Above by one pedicle, below by one pedicle, anteriorly upper part by the vertebral body, lower part by the disc, posteriorly upper part by the superior articular process, lower part by the inferior articular process, lower part by the superior articular process, and nerve root lies here, accompanied by anteriorly by radicular blood vessels. So this is dangerous because the blood vessel is there, which is supplying the nerve root. If you're injecting any particular steroid there might be infarction of the nerve root. That's why this might be very dangerous. So this needle, I need not advance a little more. First needle was intra-articular. The second needle also, I am lying over the bone there. I cannot advance. That is the final position. So these two needles, what I want to see, that I am not entered into the foramen. Sometimes by mistake, if I'm slipping it here, then I might be going into the foramen. So in the AP view, in the lateral view, I need to check that we are away from the foramen when we are doing the facet joint injection. But for these two, I have to advance the needle a little more for these two. So I'll be advancing the needle. How much shall I advance? I should be coming up to the posterior part of the foramen. Picture. Okay, this much. I must not be advancing. So needle should be as close as possible to the pedicle. And nerve root is here. So I can touch the nerve root any moment if I'm advancing it further and if I'm coming little below. So be cautious that I am not damaging the nerve root. That is very, very important. And the fourth needle, cambion strangle approach, I will also have to advance it. So I have to advance a little more. Okay, so that is the final position of this foramen. So this is the neural foramen. And if I am going in the upper part of the foramen, I am targeting the exiting nerve root. If I am going to the lower part of the foramen, I am not targeting the nerve root. Drug will go also to the exiting as well as the traversing nerve root. Regarding the exiting and the traversing concept, the third back pain evaluation class, that time I'll be talking in detail what is exiting and traversing nerve root. So this lateral view is now very perfect. Now I'll be going checking by the AP view again to see that whether my needle has moved away or not, or it is in the right position. So you have to check by the AP, by the lateral, by the oblique to tell that this is my final needle position. Yes. So this needle is still in the facet joint line. So that is the interarticular joint. This is your on the medial branch. This is on the foramen, and this is also in the foramen. So I'm happy as this as the final needle position. So these are the four important procedures, four most commonly done procedures. So whenever you'll be getting the chance to practice these procedures, do these things because these are the very safe procedures and very commonly done procedures. Any questions if you are having, you can ask me now.
So once again, can you explain which one is facet and which one is transforaminal?
This is the intra-articular facet. The needle is there. This is your medial branch because medial branch lies like this. This is the foramen, whole is foramen. This is the cambion strangle approach. As I mentioned, the nerve root is coming like that in the oblique view. So this is above the nerve root, this is below the nerve root. So this is the subpedicular approach or septangle approach for the transforaminal, and this is the cambion strangle approach for the transforaminal. So these both are transforaminal, but one is upper part of the foramen, second is lower part of the foramen. And these two for the facet joint, one is intra-articular, another is medial branch. Understood?
Sir, so there is no role of seeing a lateral view if you are targeting facet joint or medial branch.
Yes. On the medial lateral view is not going to confirm it. Confirmation is by the AP and the oblique, but the lateral view is important to see that your needle is not inadvertently gone closer to the foramen. Okay?
Okay, sir. Okay.
Any other questions from anybody?
Can you show this in oblique view?
Yes. Our oblique cord. So that it comes in the tunnel vision. Okay, so this is the oblique view. We started with the oblique view with the tunnel vision. And then we went for the lateral view and then again checking by the AP view. So all these three views is important. So as I mentioned there, in the foramen, the nerve root is coming like this. So the first needle is on the shape triangle. So this is the shape triangle. This triangle is shape triangle. And this triangle is the cambion triangle. So if nerve root goes going like this. So this is supraneural approach. This is the intraneural approach.
Sir, at times when I am giving blocks, transforaminal, safe triangle or cambion triangle, I happen to hit the bone. So then mostly I try and walk off the bone and reach the transforaminal space and confirm. So I'm like, why does that happen and how can I avoid doing it? Because
if you are doing the perfect tunnel vision, you are not going to hit the bone. But what are the bones you can hit? You see here. So one bone, what you can hit here is the pedicle. That is one of the common area where hitting the bone and then you are stripping down. That is possible. Second is this is the pars interarticularis. This bone also you can hit and you have to come laterally. So you are on the image, you see which bone you are hitting and you accordingly takes place. And if you have gone too much, then you can hit the vertebral body also. But don't do that because, in that situation, the chance, because the nerve root is coming like that. So chance of hitting the nerve root will be very high if you are hitting the bone. But if you are hitting the bone superficially, this bone and this bone, it is not uncommon. And you have to negotiate your needle to understand where you are hitting, and then you negotiate, and then you go into the foramen. Okay.
And one more thing, sir, when I'm doing L5S1 block, I find it very difficult to...
Yes, that is always difficult. L5S1, I'm showing you. Okay, if any questions from there, I'll be going into the L5S1 for those who are already doing it.
Sir, I
L5S1
have
I
a
have not
request.
shown because I'll be showing you what are the difficulties.
Sir, one
but again,
request.
those who are new, just try to understand that what are the procedures. Any questions from them, then I'll be taking your question later on. First,
one question for me, sir. Sir.
You'll be given last chance. Let the other people ask.
Right, sir.
If anybody
So
else
should we
have
bend
any
the
other
tip of the
questions.
needle? Should
Pardon?
we bend the tip of the needle? Should we bend
Tip of
the tip of the
needle has
needle?
to be understood by the lateral view. So in the lateral view,
Okay.
you have to see where is your tip of the needle, because in this view, you cannot understand where is my tip of my needle. So that is very, very important. Where is my tip of needle? So as I mentioned with the foramen, your needle, tip of the needle should be always in the posterior part of the foramen. Never go to the middle or anterior part of the foramen. Then the chance of hitting the nerve root is very high.
Actually, some of them, they bend the tip of the needle. Is it necessary, sir?
Yes, I have also bended the needle. If you're bending the tip of the needle, then it is easier to manipulate the needle. Suppose if your needle is straight,
Okay.
then what will happen?
Okay.
If you want to move it, change it the direction, you have to take whole up to the skin and then you have to negotiate. But if your tip is bent, then you can just turn bent side towards your where you wish to go, and then you push further. You need not withdraw the whole of the needle. So that is the reason why but bent needle should be little bit bent, maybe 5 degree, not too much bent. If too much bent, then it is difficult to make a tunnel vision.
Not much. Thank you, sir.
Any other question from anybody? Then I'll be taking Bindu's question.
Sir, do we need to inject dye, sir?
Yes, always. Before injection of any of the drug, you have to inject dye, and then only you understand that you are not in the blood vessel, because blood vessel is very dangerous structures, and then only you can inject the particular steroid. Before that, you cannot inject particular steroid.
Sir, needle tip position in medial branch block.
This is the needle tip position. At the junction of this is the superiorticular process, the transverse process. So the junction of the superiorticular process and transverse process, this is the position.
Okay.
Sir, how much the needle that you have bent seems to be very acute. So isn't there a chance of breaking the tip of the needle if it breaks off? I mean, like, it seems very acute, sir.
No, it's not acute because you are seeing in the tunnel vision. That's why it is looking so acute. I'll be showing you the needle. Only 5 degree bend is needed. You cannot bend it too much. Probably you are asking this one, no? This one, isn't it?
Yes, sir. Yes, sir.
I'll be showing you that needle. That the bend is actually very, very minimal. But because it is tunnel vision, you see, whole of the needle is seen only by this much. So you are feeling that it is too much bent. Bend should not be, I already mentioned, the bend should not be more than 5 degree.
And how far from the tip? 0.2, 0.3 mm. How far?
You see, can you see this? This much bend. When I appreciate very minimal bend, around half centimeter to 1 centimeter from the tip.
Okay, sir.
Very minimal bend is there. Okay, if no question, I'll be taking questions from Bindu. If anybody else used to ask any question, you can ask me. And then I'll be demonstrating the L5S1 and why it is so difficult. Those who are already practicing, they know why the L5S1 is difficult and why and how to overcome that. I'll be showing. But before that, if anybody have any questions regarding all these 4 procedures, you can ask me. Okay, no more questions. So it's Bindu's chance. Bindu.
Sir, good evening, sir. Sir, my question, sir, just request, sir, in lateral view, Sir, can you please show me the superior articular process and transverse process? I am not able to appreciate always correctly.
Transverse process will be here in the AP view. We are seeing what? Pedicle in tunnel vision. This is pedicle. And transverse process, you can see a broad transverse process.
Sir, in
And
lateral view, sir, in lateral view, sir.
I understand. I am first explaining the AP view so that you can understand this nicely. So now if I'm going on the lateral view, and spinous process is a very small one. But if I'm going in the lateral view, what will happen? Spinous process will be very broad, pedicle will be broad, a transverse process will be very small in tunnel vision. Okay? So you go lateral. In the lateral view, transverse process will be seen as a in tunnel vision, as a small circular structures. So you see, the spinous process is becoming so broad now. You see, be so big. And where is your transverse process? This is the transverse process. It is seen as a tunnel vision. It is overlapped on the right side and the left side is overlapped. So that is a tiny circular structures on the lateral view. Understood? Bindu?
Yes, sir. Yes, sir. Thank you, sir.
Because it is overlapped with other structures, it is not seen very clearly. But you can part of it, you can see this was the this was the transverse process.
Sir, you said that if we advance the needle further in the foramina, we might be as well injecting the particular thing in the radicular vein. But for the needle to reach the radicular vein, will we not be hitting the nerve first?
Yes, obviously. That is the reason why the before reaching to the radicular vein, first is you are puncturing the blood vessels. But there is anatomical nerve root, but anatomical variation. You know, as I mentioned, I have drawn it. So normally the nerve root is like this, and radicular vessel is like this. But that is the reason why if you are going, most of the times you will be first hitting the nerve root, and patient will be shouting, and patient might be kicking you also. So the advance is very slow. But sometimes there might be anatomical variation. So the blood vessel, instead of here, it can be here. And your needle might be reaching there.
So
understood?
If we happen to do that, can we get to know of the infarction that we have caused on table itself? Or it will come later?
You should not be landing up with the infarction if you are giving dye. Okay? So you should be giving the dye to see that your dye is not vanishing partially or completely. Then only you are giving the injection. So if you are following the protocols, you are not going to land up with the things. What will happen initially if you are at all injecting the particular steroid? You cannot take it back. First of all, you understand this. If
Yes,
you are
sir.
given the particular steroid, there is no remedy for these things. You cannot do anything. No management. You have to just wait and watch. So what will happen? Initially, there will be ischemic pain because the patient will be having the ischemia of the nerve root. So immediately, very severe ischemic pain will be there. And that pain also will be having the neurogenic component because nerve ischemia. So there will be tingling, the heaviness, weakness, all those things will be along with the pain. And then gradually, the patient will be recovering a little bit. But the numbness and radicular symptoms might be persisting. It is a dangerous condition. So to avoid that, you should be always only on the posterior part. If you are in the posterior part like this, not advancing anymore, then you are not going to hit the radicular vessels. And still, if you are injecting the dye, you are very much sure that you are not into the blood vessel.
Okay, sir.
Okay, so now L5S1. Why L5S1 is difficult? Because L5 vertebral body, H1 vertebral body is very much bent. So you see here, the lower border of the L5 is very difficult to understand. It is so much of these things. So first basic steps are similar. What is the basic steps? Basic step is we are making a true AP. So after making a true AP, what we will do? This is a true AP. True AP means the distance between the from the pedicle is same. True AP. Next, what we will do? We'll be going for the cranial tilt to make the end plate parallel of the L5. Little more. Okay. So now the end plate is parallel. Now I'll be making oblique. Just follow the similar steps. So here, what is the additional problem? Number one is this tilt is too much. And number two is, if see, iliac crest is coming and obliterating these things, all this area, that is making the very difficult things. So you have to compromise somewhere with the lateral bend or to oblique. So if I'm doing more oblique, you see, the iliac crest will be completely obliterating the foraminal area. Or oblique.
Sir, can you please show it with markers?
I'll be showing. So you see now the arrect oblique. So now you see the iliac crest is coming and completely, this is the pedicle. So the below the pedicle, so it is completely obliterating this foramen. So what you have to do? You have to compromise there that you don't do the lateral bending too much. And try to identify the subpedicular area. So this is the pedicle, this is the pedicle, and this is the subpedicular area. This is the, and another problem is transverse process is broadened in the L5S1 in majority situation. So you see, this is the superior process, this is the inferior process, this is the transverse process, broadened transverse process, this is the iliac crest. So all these structures are making the window very narrow. So this much is the window here. So you have to go there, and in the lateral view, you must not be going too deep, otherwise you are going to hit the nerve root. So in this view, I'll be going in the tunnel vision, just below the pedicle. That means this is the area where I'll be targeting. And then I'll be going in the lateral view, and then we'll be advancing further. So I'm putting the needle. Okay, somebody was asking, my needle was, you know, this much bend, yeah? This much bend. So not much bend. I'll be using this one. Okay, so first is area where I'll be injecting picture. This is the area. In tunnel vision. Picture. Okay, now it is nice tunnel vision. I'll be advancing further. And now I'll be going back to lateral view. So my needle was here. This is my needle, below the pedicle. Okay, so what do you have to understand? Here the problem is iliac crest will be covering, and you might be having difficulty to understand where is the foramen. But anyway, you can see the foramen, and my needle is already peeping in the foramen just below the pedicle. So that is my, this not this much, little less. But if your needle is very close to the pedicle, it is safer, because nerve root and radicular vessel is little below. So this is the foramen. This is the foramen. My needle tip is coming here. It is very close to the pedicle. So, and I have not gone too deep. So this is very safe. I'll be checking by the AP view also. Okay, so fine. I'm there. So I want to come. Okay. So fine. So that is the final needle position. It is below the pedicle, and we are into the posterior part of the foramen. So what is the trick here to do the procedure? Number one is don't make too much oblique, because iliac crest will be covering. Second important problem is because of the broadened transverse process, and the space is very narrow. But the basic steps remain same. So you just identify the area below the pedicle, go by tunnel vision, and in the lateral view, try to identify the foramen and try to remain in the posterior part of the foramen and as close as possible to the pedicle. So is it clear?
Sir, at times in my practice, when I have tried to square the vertebra very properly and then have attempted needling, then most of the times I end up hitting the bone. So in 2 or 3 cases, I have compromised on the squaring of the vertebra and then proceeded. I can't
You have
understand.
to adjust it more and more, the L5S1 will be problematic for everyone in the beginning. More and more you are gathering your experience, you will be able to understand that where you have to compromise and how you are going to do that. So exactly the position might not be same in every the patient. So you have to the compromise in some areas, like as you told, sometimes you are compromising in making the squaring, sometimes compromising in making a true the Scottish dog image. So you have to compromise with that, and you may not be able to do it classical way. But the thing is, you must be doing it very safer way. That means you should be always in the posterior part of the foramen, always, 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 always. Then you are safe.
Okay, sir. Thank you, sir.
Okay, so any more question if it is there? Otherwise, we'll be saying good night for today. Okay, so good night for today and see you on the next day with the second module of the back pain evaluation, where we'll be starting with the back pain evaluation 2 with the red flags and all the things that I mentioned. So thank you and good night.
Thank you, sir.
Thank you,
Yes,
sir. Thank you, sir.
Abdul Alim, are you asking me any question?
No, sir. Thank you, sir.
Okay, thank you. Okay, fine. I was thinking any questions
you,
because
sir.
we are always answering each and every questions, So thank you very much. And if
Thank
still
you,
you
sir.
have any
Good
question
night,
when
sir.
you're going to the recorded lectures, you can ask me on the next class before you are starting with the second module.
From where to read this in detail.
So these
Recorded
recordings will
class.
be there, go through it again and again and again. And some of the study material I'm providing, I'll be providing some study material as well. But exactly if you're asking which textbook, so few textbook already we have suggested. One of is our textbook, basic, very, very basic book. Then you have Prithviraj's book, then FIPP book. The other few books, FIPP books is also a very important book. So you can read these 3 books. FIPP book, you just search in the net, in the Amazon, the FIPP book, that is one of the advanced book. Prithviraj's Practical Management of Pain is another book. And obviously, the Basics of the Pain Management by us is another very basic book. So you can read these books. Okay, so good night for today.
Good night.